question.
Hello everyone and welcome. My name is Martijn Verhulst from Sunstar and I'd like to welcome everybody for the first episode of our Let's Talk Oral Health webinar series of this year. And in this year's series, we will focus on home-based oral care seen from the perspective of several dental specialties. And today we'll kick off with periodontology, but before we do so, I just want to remind you that if you're watching and you have any questions, please feel free and ask them in the chat function on YouTube. If you're watching from the Eventbrite page instead, you won't have this option. So you have to click on the Watch on YouTube button on the bottom left corner of the video screen, which will take you directly to YouTube. And of course, when you're there, just let us know how you're doing and where you're connecting from. Also, if you are new around here and you want to watch back last year's webinar series on oral health at different life stages, all episodes of that series are freely available on the same channel. Just give it a go, hit subscribe if you like it, and if you haven't done so already. And yeah, let's get into it. And I'd like to start by inviting the first speaker of today into the live stream, Professor Dagmar Else Slot. There we go. Dagmar is a very well-known dental hygienist. She's an educational expert, a clinical epidemiologist. It's a mouthful. She's a full professor of oral prevention at the Department of Periodontology at the Academic Center for Dentistry in Amsterdam, in the Netherlands. Hi, Dagmar. It's such a pleasure to have you on the show today. How are you doing?
I'm fine. I hope other people are fine as well. We are both in the Netherlands. If I look out the window, it looks like we are hitting November. It seems like almost autumn, but hopefully we are back full in spring and looking forward to all new things that happens in 2022.
Exactly. It's terrible outside. You're completely right. But hopefully it won't spoil the party of today. I'm sure it won't. Yeah, again, thanks for being here. Maybe it's now the best time to introduce the second speaker of today, Professor Filippo Graziani. Let's see if we can get him on screen. There he is. Hello, Filippo. Filippo is a full professor in periodontology at the University of Pisa, where he coordinates the subunit in periodontology, halitosis, and periodontal medicine. He is former president of the European Federation of Periodontology and the visiting professor in periodontology at the Eastman Dental Institute, University College of London. He's also honorary professor of the Faculty of Dentistry in Hong Kong. Hi, Filippo. It's so great to see you again. How are you?
Hello. Hi. I'm very well. Thank you, Martijn. And I will also send the keys to Professor Slot from here. I have to say that here in Pisa, the weather is glorious. There is not even a single cloud, but it's a bit chilly. It's like 13 degrees, which is normally this time of the year should be a bit warmer. But
yeah, right. It's normal for us to be jealous of the weather in Italy. We're used to it. So yeah, we know how it is. Yeah, well, for those who just joined the webinar, again, welcome. We will be talking about home-based oral care from the perspective of periodontology today, together with these two amazing experts who apparently also know each other very well, right?
Well, yeah, yes. We know each other for a long time already.
A long time, yeah.
We do research in the same field, and that's the nice thing of doing research in the same field. Sometimes you connect because you have questions on the content of a paper, or you want to request data of a paper, or you want to discuss a philosophy, and that's what we sometimes do for many, many years. And sometimes we have the pleasure to speak together on the same meeting. So that's the reason we know each other.
Yeah,
good. And I guess you're also, interested in more or less the same topics, both in research and in clinic. And I think that's a good start for our first question today. Question to both of you, because I see both of you at least as global ambassadors of your profession. Filippo, you for periodontology, and you, Dagmar, for the dental hygiene field. And I wanted to ask you, what makes you so excited about your specialty, and what message are you hoping to convey today? Who wants to start?
Well, there are different numbers of things that make, at least myself, happy of my profession. My profession is one of the few attempts where you can combine clinical research as a daily routine. And basically, the fact that periodontology has the intrinsic capabilities of making measurements in the normal routine practice makes possible that you take decision based on data. And it's not just based on the opinions, the clinical experience, or the observation, and so forth. So that is constitute, I think, and foremost, an important tool of communication. It's a language. When I speak with Dagmar, and we sometimes have a chat and in the evening and night time about data, about exchanging of numbers, but my numbers are her numbers and vice versa. So that is a language that allow us to communicate. And the overall results is that the profession of periodontology has dramatically increased the efficiency in the performance years by years. This is beautiful, and it's beautiful to be part of it. So this is what I personally like. And what I will convey today is most probably the impact that we have from the knowledge on the usage of interdental devices and how to clean interdentally.
How about you, Dagmar?
Yeah, I think if it comes to the profession, I think the dental hygienist is a beautiful profession. It gives us the opportunity to collaborate with a patient and with a dentist, and that is a group of three where I really like to work in and provide information to, and I still practice myself. And I think the dental hygienist has the position in daily practice that is a rather low-key role to discuss with the patients about oral self-care. And my passion is definitely oral self-care, which is a very important part of non-surgical periodontal therapy. And I think besides prevention of caries, that's the main goal of the dental hygienist. And I have the opportunity to do research, clinical research, and a lot of literature research, and to provide information to the profession, which the profession dentist and dental hygienist can use in daily practice. And I also get a lot of questions from dental hygienists and dentists, which provides me new ideas for research and philosophies to discuss. For example, with Filippo, what we can do to enhance the profession and to enhance the self-care of patients in the end.
Yeah. Good. Yeah, fantastic. I think we have a lot to look forward to today and to discuss. So it's great to have you both here, and I'm sure we will benefit a lot from your expertise. Maybe let's just dive into the conversation, and begin by looking at our first discussion point, because you already mentioned it, Dagmar. We often talk about the importance of self-care at home, but what exactly are the crucial phases of periodontal treatment that can actually be managed by the patient, him or herself? Maybe you want to start, Filippo, with this one.
Well, of course. I mean, periodontology cannot exist without a patient. I mean, the point is that periodontal treatment, cannot exist without the direct involvement of a patient. And this is true for any chronic diseases. I mean, you can't possibly think about diabetes or hypertension to be put under control without the involvement of the patient. And therefore, periodontitis and periodontal treatment is exactly thus. Not a single phase of treatment may succeed unless the patient is collaborating, unless the patient is involved. And to be involved means much more than just being informed. The patient has to be motivated to the point that something triggers inside him or her, to the point that they will start to adopt some behavioral changes. And this is the famous step 1 of periodontal treatment. Behavioral changes that will imply, of course, some change of habits that will ultimately lead to the crucial aspects of the treatment. Basically, not a single session of non-surgical treatment will be successful without the patient being capable of keeping the plaque under some sort of a threshold. To give you an idea, if you would go for a surgery on somebody that is not capable to brush properly, you'll actually determine a damage. So doing a surgery on somebody with a highly infected dentition, somebody with high level of plaque, will actually imply creating a sort of a damage to the extent that it's like accelerating periodontitis of 4 or 5 times. And let alone the last phase, which is supportive treatment. supportive treatment will never work unless the patient is capable to, in a way, maintain themselves. That's why it is called supportive and not maintenance anymore. It's not the professional who's maintaining the patient. It's the patient that will maintain themselves. The professional is just supporting the patient in this practice. So oral hygiene is really the first foundation monument of the entire periodontal treatment. If the patient cannot keep plaque under control, there is no way that we can produce periodontal treatment to an effective level. Now, the question is, we tend to, even the language that I was using is kind of deferring the problem to the patient, like if the patient is not capable of. The issue is that any patient is capable of everything. It's just the professionals that needs to find the way to make sure that the patient will change. And that is the challenge of our work, making sure that we not just convey some messages, but we also stimulate the change in the patients that we have in front of us. So surely you need to have a good oral hygiene from the patient in any aspect of periodontal treatment. There is no discussion.
And I suppose, sorry, Dagmar, I see you.
Yeah, I absolutely support what Filippo says. And I think there, from a dental hygiene perspective, not so, yeah, that's partly part of the dental hygienist. But I think from the dental hygiene perspective, there is also a need to say that this self-care is very important for people who will get dental implants before and after they got the implants, because the collaboration we see between dental hygienist and periodontist is quite good already. But with implantology, there is at least room for improvement, to say that way. And that also applies to restorative dentistry. I think that's one of the things that Filippo also addresses. If the mouth changes because you got periodontal therapy, or the mouth changes because you got dental restorations or a dental implant, people need to learn how to keep their oral environment clean. And if the mouth changes, they need re-instruction on how to use their oral hygiene tools. And I think that's, from that perspective, dental hygiene is also very important in order to collaborate with these two professions, because these are two other professions beside periodontology, but rather close to periodontology.
No. And I think that if we go and make also a step further, thinking about implant treatment in a periodontitis affected patient, we know for sure that one of the determinants of the success of implant is actually the level of plaque and inflammation. And the patients that are undergoing implant treatment with previous periodontitis, if they're not having a supportive periodontal treatment throughout years, they are more likely to lose bone around their implants, or even to lose their implants. And there are pretty strong evidence up to 10 years. So I would echo what Dagmar was saying. We surely need it even in implants.
Yeah, and that always start with a good collaboration between the patient, the dentist / periodontist / implantologist, and the dental hygienist, in my perspective. I think doing it without a dental hygienist is rather difficult. I don't obey countries who don't have the profession, but I'm biased, of course.
No, well, the thing is that, of course, we come from countries where there is a dental hygienist, you rightly said. I mean, in some countries where there is the absence of the legal figure of it, it's a huge problem because, and for example, I was talking recently to some colleagues in France, where periodontists have to provide every single aspect themselves. So the implication that from a practical standpoint, any clinician would rather spend their time placing implants or doing some sort of a more articulate treatment, because of course they have surely the higher economical advantage, higher satisfaction, and so forth. But therefore, nobody would actually take the patient on board in the long run for supportive periodontal treatment, which is, you can't do perio without supportive periodontal treatment. It doesn't make any sense. It's a chronic disease.
You've both been talking about basically, oral hygiene during treatment, either of periodontal diseases or peri-implant diseases. But how about prevention? I think is that also, I think even before there is disease, a home-based oral care is important, right?
Well, yes, very much so. I mean, I'm sure Dagmar, in this regard, Dagmar is one of the most competent person in the world with the data that she produced. But surely the main concept here, and I think it has to be clear, that to prevent periodontitis, which is a chronic, terrible disease that is associated not just with tooth loss, but with important systemic implication, you need to make sure that you make a prevention, and prevention of periodontitis is the treatment of gingivitis. Mm-hmm. So every time that you treat gingivitis or you maintain somebody healthy, you are actually preventing periodontitis. So this is why it's so crucial to focus on the healthy patients, or at least the patients that are not affected by periodontitis, because that is really the first battle to be won. And I mean, Dagmar has plenty of data in this regard.
Yeah, and I think what we see in life, we now start the whole trend of living healthy. We see that students at a high school learn how to cook, how to make healthy choices. And I think it's also a time that we start to learn high school children how to brush, because what we see is that it's very rare that people need to do something twice a day and they don't get a proper training for it. So I think from that perspective, in the light of prevention, having oral hygiene as part of integrating becoming healthy or stay healthy in the whole wave that's going on right now, in addition to what Filippo says, I think having that as an integrated part in your education would be very helpful. And that's not something that it doesn't not only happens in the dental practice, but also happens in other topics during your life in other settings like schools or so.
Mm-hmm. It's an interesting vision, absolutely. So bring back the school dentist.
I don't say bring back the school dentist. That's a different thing. But at least bring some information. As you see that a general physician got 1 or maximum 2 hours of dentistry in their education. I think that's rather low amount of hours. Yeah. And I think if we put so much effort in living healthy, making healthy choices, a brushing exercise during your school years is not a bad choice.
No, absolutely.
No. And the thing is that we just kind of getting understanding now of the importance of a good plaque control. I mean, of course, we as professionals, the oral cavity, we always know it, but lots of efforts have been put on technical dexterity. The majority of myself and my colleagues, you were studying to try to become better in using the hands to solve problems. So we've been taught how to treat, let's say, how to address the treatment of the cure of a disease, which is very different from the model of preventing something, which is what Dagmar was saying is maintaining wellness, which is really the new barrier, the new, front line of medicine, which is keeping people healthy instead of trying to solve a disease. It's something that it doesn't belong to the DNA of a doctor. I can tell you, we haven't been taught this. So this is a tremendous shift in the change of the mentality. Now we know very much so that if I would keep the plaque under control and inflammation under control, that would have a tremendous protective effect, even on systemic health and quality of life. But we know it now. I mean, it's something that, and when I say we, I can say that myself, maybe, and Dagmar have exchanged some data. We have discussed it. In the last 10 years, we published dramatically. But when we had a meeting within the European Federation of Perio and the American Academy of Perio on systemic involvement of perio was 2013. So it's not even 10 years ago. So by the time that this reaches the routine practices all around the world, it'll take time. So we just have the first perception of the importance, but this is exactly where we need to go.
Yeah. Absolutely. So, I guess, we've been talking about home-based oral care and oral hygiene in general, but maybe it's a good point a good time to get a bit more specific, because I presume toothbrushing is probably by far the most adopted oral hygiene habit, and it's part of the daily routine of many people worldwide. But the question is, when we're talking about home-based oral care and periodontal health in particular, is toothbrushing already enough, or is it crucial to also clean interdentally?
What we studied already 10 years ago, starts becoming old, is that we evaluated, based on all the studies, what is the effect of a single brushing exercise. And that means, there are different models to evaluate the effect of a toothbrush. One is you provide people a toothbrush and you wait for 2, 3, 4 weeks or maybe 6 months, and you evaluate it again, and then you can evaluate it plaque removal, and you can evaluate it gingival health, if there is any gingival inflammation. A kind of proof of principle model is a single brushing exercise, which means you evaluate it. I measure the dental plaque right now. I provide you a toothbrush. You do your brushing exercise. Can be with an instruction, without an instruction, with a mirror, without a mirror, with a certain toothbrush or whatsoever, and then you assess the plaque again, and then you can evaluate what is the effect of that particular exercise. And what we did is we did a systematic review where we evaluated what is the effect of a single brushing exercise with a manual toothbrush. We found about 40 studies, and we found that we're including about 10,000 people in total. And what we found is that only 42% of plaque is removed with a single brushing exercise with a manual toothbrush. We did exactly the same with a power toothbrush. And with a power toothbrush, we found that was only 46% dental plaque was removed. Of course, you can discuss, this is not a direct comparison, because we know from the direct comparison, there is a difference between a power toothbrush and a manual toothbrush, which is significant, by the way. And that has been established already in 2010 by the Cochrane collaboration, but also more recently after reviewed by different groups from America and groups from Europe. So there is not much discussion about that. But if you take in account that with a toothbrush, you take on average between 42 and 46% plaque removal, there is quite a lot of room for improvement. And as a toothbrush cannot enter the interdental area, I think by definition, a toothbrush, if you have gum disease, so if you have periodontal disease, there is that's not enough. You need something to use interdentally. There is always the big discussion where you should you clean interdentally if there is no bleeding, and it seems that for you brushing is enough. There are more or less 2 churches. Do you agree, Filippo?
Well, yes. Let's put things historically in perspective, if you allow me. So, my profession has been forced by maybe 25 trials, maybe 28, no more than that. But I read them a lot as a reviewer, as a clinical researcher, but there are, let's say, between 20 and 30 trials that have changed my professional life and really shaped my professional activities. And one is really the pillar of it, which is Axelsson and Linde in 1981. And I like always to quote this paper because that really gives you the importance of it. We're talking about 2 groups. One is populated of more than 500 patients. The other one is 200 and so, that have been really treated in a different way. On one end, you have people that are attending once a year sort of a dental cleaning, and that's it. And they keep brushing by themselves, whereas the others are seen every 3 to 4 months. And every time they're not just clean, but they also receive motivation and instruction, focusing especially on interdental cleaning. And the results are important because they have a follow-up up to 6 years, so it's a very long follow-up. And most important, results are presented in both data, buccal and lingual versus interdental. And what was clear from this data is that basically the people that is not capable, people that has not been formally taught and at the same time followed intensely throughout the time, kept accumulating plaque only interdentally, because baccolingually and occlusally, people may get better by themselves. So if I tell you to brush more, everyone, even without a training, can brush better occlusally, baccally, or lingually. However, interdentally, plaque, of course, stayed up to 100% of the time. I'm saying 100% because, of course, people doesn't brush normally in between teeth, so the plaque was still very high. So what is happening in this group, which is the control group, that up to 6 years, the people would develop more and more inflammation, even baccally and lingually, which means that if you don't brush in between teeth, the inflammation will also go where the plaque is not present. That means that the determinant of inflammation is what happens in the papillary area, what is happening interdentally. And therefore, in the test group, where the plaque interdentally was kept under control, no inflammation and no caries developed throughout the 6 years. So to me, this is crucial. It's really the paper that really stresses not just the importance of it, but the paramount importance. It means really that cleaning interdentally is the most effective tool you can give to your patient. This is why, for example, in our clinical activities in my centers, the first things that we do, we teach patients to brush interdentally, to clean interdentally. Then we get along with all the rest, toothbrush, toothpaste, and so forth. But interdental brushes, for me, is the key essential point of maintaining let's say, a disease-free dentition throughout time.
Interesting. Do you have anything to add, Dagmar? You probably completely agree.
Yeah, no, I absolutely agree, and I absolutely agree that the Axels and Alinde study is a fundament of periodontology and self-care.
It's fantastic. A paper from how long is it? More than 40 years ago. Still, laying the foundation for modern clinic. I think it's amazing. Yeah, absolutely.
Yeah, and I think it's important. If you don't understand your past, you don't can work in the future, and that's a famous saying. I think when it comes to that's what Filippo says. Some really classical studies that moves us forward still till today.
Yeah, absolutely. Okay, yeah, I think it's pretty clear that toothbrushing, from what you've said, from the data that you've discussed, toothbrushing alone is not enough, and we need interdental cleaning for a more complete oral care routine, so to say, to ensure optimal periodontal health. But that raises the question, what do we know about the efficacy of different interdental cleaning devices?
Yeah, together with my coworker, if I may take this question, Filippo.
Of course.
Together with my coworker, Fries van der Weijden, he always tells people that we start a mission. In these days, it sounds a bit weird to start a mission, but a mission is that we focused from 2007 on. We took the philosophy to map out oral health, oral self-care, and then we start with a whole series of systematic reviews on self-care. So we did toothbrush studies I just discussed, and we did more. We did on floss, we did on wood sticks, we did on interdental brushes, on oral irrigators, etc. And we did it in order to map out what is the effect we know and what is the research we need for the future to make decisions. What we for instance developed is the systematic review where we evaluated floss. That floss was not so effective on plaque removal, not on bleeding, and not on the gingival index. We evaluated the wood sticks. That wood sticks do have an effect on reducing the bleeding tendency. We did a systematic review on interdental brushes, which showed that it has an effect on a plaque reduction and a bit on probing pocket depth. In the meantime, also the Cochrane collaboration came up with two systematic reviews, one on floss and one on interdental brushes. More recently, we evaluated, by then in 2008 also, we did the oral irrigator. More recently, we evaluated the rubber picks, and what we also evaluated in 2015 for the European Federation of Periodontology, we did a meta review. So we did a systematic review about systematic reviews. And that was the Sonja Salzer paper, which was really a fundament for the guidelines for the prevention workshop of the EFP. And more recent, what you see is that the advantage of a systematic review is a network meta-analysis, and a group from the US, from Kotsakis and Liang, worked on a network meta-analysis where they evaluated all interdental devices. And they did it, they combined direct and indirect evidence. So you can compare not A versus B, but you can combine A, B, C, D, E, F. And what they found out in the network analysis, that the interdental brushes and the oral irrigator rank high for both bleeding tendency and plaque removal. And they also could combine different outcomes with each other in their multiple outcome network meta-analysis. And that's, I think, currently the state of the art, what we have on interdental cleaning devices, what there is on evidence and presented. What I need to say that if we put so much effort in our information to patients, it's rather sad to know that we don't have, we have only, for instance, 11 studies on dental floss, or we have 8 studies on dental brushes, or 8 on wood sticks. I think if you see the amount of effort we put in our instructions, that does not reflect the amount of studies that are available. And from that perspective, I think interdental cleaning is maybe not the most sexy tool to evaluate it in a trial or to get funding for, but there is for sure a need to get funding or get opportunities to research it well in current status patients and in current products, because what you see that those products are evaluated as well. And we evaluate also, what we also change is our instructions to patients. And that's something I think if there is one way to improve our profession and our self-care, is also to redo some studies in the near future. But I know that Filippo does his best on his interdental cleaning device studies, but it's difficult to get funding for it. And doing research in academia is still a bit of a rat race for funding as well. So from that perspective, doing paper research is nice, but doing clinical trials is maybe better sometimes.
What do you think, Filippo?
Well, you know, I mean, as a trialist, I mean, I have to say this is really spot on. To give you an idea, we did approximately 4 trials in this topic, and the last 2 that came out quite recently. And they are not easy trials for, first of all, for the study design, but most importantly, as Dagmar said and pointed out, they're really not sexy from a, let's say, from a grant standpoint. All the time that I ran this trial, I had to do my funds. So basically, I got funds from some researchers, and then I allocated a bit to these trials just because I was curious, because I wanted to know how it worked. But I will never get money to run a trial for directly designing interdental devices. I mean, there is no discussion about that. Having said that, I think what we personally gathered as an experience is, for me, what is crucial, and this is just a clinical issue that we then translated in research, is that to assess the effectiveness and the performance of an interdental device, you need really to make 2 different clinical scenarios, which are people that have intact papilla versus people that have lost attachment, as in periodontitis. Because these are 2 different words. I mean, this is something that any clinician would know when they're making some origin extractions. But the data, most of the times, are either done on healthy patients or patients with gingivitis, or a sort of a undefined sample where you don't know whether people was affected by periodontitis or not. This is why, for example, we designed the same trial addressing different type of interdental clinic in two different populations: periodontitis affected population with interdental attachment loss, or people without interdental attachment loss and actually without periodontitis but only localized gingivitis. These are really the two trials that we've been publishing the last 3 years and allowed us to gather, I'd say, quite a deal of information on how to clean effectively interdentally in the two different samples populations.
And what were the main differences you found between the perio group and the subject with the subject with the intact papilla? Were there major differences, or were your findings more or less similar?
No, well, actually, they were kind of similar. They're not exactly similar. They're kind of similar. Let's say that the common trend is that in both samples, flossing wasn't really capable of providing an added benefit to manual toothbrush, which is something actually is consistent with a great deal of Dagmar's literature. I mean, flossing yet was taught by professionals, but didn't really determine important results. In fact, it didn't really determine any difference with just normal brushing. And interdental brushes was clearly superior in both settings, both people with localized gingivitis and people with periodontitis. It's something that we would have expected. What we didn't expect, though, was to see that even interdental rubber picks were actually as effective as interdental brushes in periodontitis affected patients. This is a novel finding, which is important. But what is also very nice is to see that in subjects without periodontitis, they were equally effective in terms of plaque control to the interdental brushes, but they were more effective in terms of reduction of inflammation. And I think this is very important because the only explanation that we could find in the idea of removing the same amount of plaque but being more effective in terms of bleeding was that most probably the rubber picks would determine a sort of a massage effect on the papilla, sort of a Dagmar doesn't like very much this term massage because, of course, we discuss me and her a lot about things. But maybe it's just a squeezing effect.
I didn't know that the gum was a muscle. You need a massage. That's what I always bring up in this discussion. Huh?
Yeah, but you're too strict. I can massage also hairs, skin. You can't just massage muscles. But I think what is important is that this kind of a frictional effect on the gum, well, maybe a squeeze effect, I don't know how to define it, but would most probably determine a sort of effect at the blood vessels level, on the inflammatory level, to the point that there is less inflammation at the same amount of plaque reduction. So to answer your question, the results are kind of similar in a way that interdental brushes work more than floss in both samples, and that the interdental peaks were working as equal as interdental brushes. That was also a novel finding in both samples, but that in people without periodontitis would actually be slightly superior. That is surely a novel finding.
What would be your hypothesis then, Dagmar? Talking about this reduction in inflammation with the soft picks. Now I'm curious.
Yeah. I always joke about that. Has to do with a long story. When I was a teacher on dental hygiene school, we had a lot of students who said if they had their exam of instructing a patient, they say, you need to do something interdentally because you will give your gum a massage. And that's what I said. Of course, when I was trained, I did exactly the same. And when I became a teacher, they learned me that was not correct because the gum is not a muscle. It's with me in my career for many years actually. Right. What I think, what Filippo says, there is a stimulus what at least takes care that the inflammation become less or less prominent on a certain way. I don't know what the actual effect is, but I think on one side, I don't like the terminology of a massage. On the other side, if we tell people massage, professionals or non-professionals, just regular patients. I think everybody understands it. So
Mhm.
I may be changing over back to massage again, Filippo. I will tell you next time we meet.
Let's see it. Let's see it. Europerio. Maybe we can conclude
Yeah.
the matter.
Of course.
Yeah,
We
exactly.
can make a symposium.
Exactly. But yeah, maybe let's move on. Talking about massages, because the evidence that we have on the efficacy of interdental cleaning devices, I guess it's only part of the story. Because this, I mean, you already mentioned it in the beginning, Filippo. What you also need is your patient to be compliant to your instructions and, actually use the tools that he or she needs. So that brings, the question: what do we know about patient preference, compliance, and motivation as it relates to home-based oral care, and more specifically to oral care devices?
Well, I think Dagmar actually has the data on this. I mean, I can just present our clinical feelings, and
Yeah.
of course,
Yeah, what we know from a rather recent study is from the Ken Haynes, the database, the national database from Korea that evaluated over 10,000 people, that showed that only 13% brushes less than once per day. So at least the rest of it brushes once or more, or twice or three times a day. So that's what the Korea database shows. And that also shows that 63% does not use any interdental device. What learns us that we as a profession, there is still room for improvement to guide our patients to interdental devices. This is data from Korea, what is a very Western orientated dental wise society where hygienists are having a firm position. So from that perspective, we can transfer that to a certain way to Europe. We know that data, for instance, from a database from a survey from Sweden, that only a few uses floss, and almost 40% of the people use a wood stick. But Sweden is a wood stick country, like other Scandinavian countries and the Netherlands. They are pretty wood stick orientated from a dental profession. That's not in every other country in the world. What we know from a recent study from our own group is where we evaluated based on a trial. No, not a trial. We retrospectively we evaluated people during non-surgical periodontal therapy in a perio practice, so the active phase of non-surgical periodontal therapy, and we evaluated by the oral hygiene behavior questionnaire whether they what was the improvement of oral hygiene. And what we saw that almost half of the people who attended the perio practice already brushed with a power toothbrush, but after the non-surgical periodontal therapy, it's what 85%. So then you can see that instructing your patients, at least you see a behavior change in which product they use. That's the same with 3 minutes of brushing. Only 30% told in the beginning that they brush at least 3 minutes, but after the non-surgical periodontal therapy phase, with a lot where instructions is a very important part of it, of course, it was 64% who brushes at least 3 minutes. We saw exactly the same for interdental brushes. It was in the end 75% or so, and the wood stick was over 50%, which almost both doubled by the instruction or during non-surgical periodontal therapy. So what you can see that based on instructions, so based on our suggestions to patient, oral hygiene self-care is improved. And I think that's very nice to know that although not many people use a product, if people got information from us during active periodontal treatment, at least they change their use. And I think that's very helpful for at least for ourselves to know that if we give an advice, it's taken.
How about when you compare different oral care devices? What's known from research in terms of patient preference?
Well, Martin, I think what is kind of clear from research is that, which is the same problem that we have as clinicians, which is, for example, for floss. I mean, the one of the crucial aspects in research for any device is not just the amount of plaque that the tool removes, because that is the efficiency, but also to understand how many sessions you need per patient in order to see that tools to be effective. What I'm saying is that floss may be dramatically effective in my hands, in Dagmar's hands, in your hands. Somebody is a professional, knows the anatomy, and have a good dexterity. To bring to the same extent, Miss Maria, who comes to my practice, it will take me many, many sessions. Surely interdental movement, whether these are brushes or picks, it doesn't matter because the movement is exactly the same, is easier because it's easier to transmit and it's easier for the patient to check the effectiveness. And most important, it is also very democratic because you'll find yourself easily applying this tool between a 6 and a 5 and not just between the central incisors. Whereas when you teach floss, we tend to teach floss how to use it in the interdental papilla of the central incisors, which is a papilla that most of the times doesn't need to be brushed because the disease is back in the posterior areas. So surely in trials that comes as well, the fact that the floss is so not effective, it is most probably due to the fact that in any trials, maybe we have 1, 2, or 3 sessions. We don't have 12 sessions of floss teaching. It may happen that with repetitive sessions, some amount of patient might be able to use that effectively. But then the question is, why bother? I mean, why do we need to make all these things when we can be more effective and in an easier way with just a different tools?
And I think
surely people. I'm sorry.
No, go ahead.
No, I was saying that most of the time that I mention this data, then I'm always refer to the point of the concept of the interdental contact point or caries prevention. But in fact, there is really not that amount of literature supporting the usage of floss in terms of caries prevention. There is something on kids that, published by Ujuel very nicely on JDR that actually showed that it might be effective if the dentist is passing the floss to the kid 4 or 5 times per week.
No, actually, it was a hygienist. Hygienist went to
fine, I'm sorry. Let's say an oral care professional. So just
okay, I agree.
On the safe side.
To be ecumenic. But I think what is important is that when I talk, for example, we had the EFP ORCA workshop a few years ago, and I was talking with the people on the ORCA in my room, in my group, and they actually were all against floss because they were saying, floss is actually opening the dental contact point all the time that you're using it. So, I just wanted to finalize this because otherwise, of course, we're focusing on gingival inflammation and periodontitis and gingivitis, but there is also the other aspect, which is caries, which is as well not dramatically supported.
Yeah, and I think what we have learned from a recent study from Germany, that in long-term evaluations from data obtained from Germany, and they evaluated data from the late 90s, 2005, and 2015 or so. And together they evaluated what is the effect of interdental cleaning together with a powered toothbrush. And then they showed, that was the first time they showed that if interdental devices are used, you also reduce that you maintain more caries-free surfaces. So it seems that there is a trend if you do something interdentally, that you maintain more caries-free surfaces. But when it comes to patient preferences, one of our latest systematic reviews was on the rubber Bristol interdental cleaners or rubber picks or laminate cleaners or whatever you call them. I think we all know what we mean. we did a systematic review, and we evaluated studies with a single use design. So you evaluated, you measure the plaque, you give the product, you evaluate it directly after product, but also with a longer follow-up. And it was compared as an adjunct to toothbrushing, compared to floss, and compared to interdental brushes. And what we saw, that there was hardly no difference between the rubber interdental bristle cleaners compared to floss or interdental brushes, and compared to interdental brushes, that was pretty new. What we also could do in that perspective is that we could evaluate the participants' preferences, and there were 4 studies that evaluated the preference of patients of a rubber bristle interdental cleaner compared to an interdental brush. And in all those 4 studies, participants preferred the rubber interdental picks over the interdental brushes. Then there's always the discussion, is this for all groups? And that's something that Filippo already pointed out before. But at least it seems a tool that is getting a more established position than it had in the past. And that also has to do that the product is rather new. The research, the first study is done in 2006, and the latest studies are published in 2020, I think, 2020, last clinical studies. So more studies are most probably coming up, and that you see that just new player on the market changed a bit the view of interdental devices, and maybe change definitions of statements of, for instance, the EFP in the future. Do you agree, Filippo?
Oh, yes, indeed.
And what could be the reason why these rubber bristles interdental cleaner are preferred by the patient? Was it investigated? Was it asked? Why? Or
they ask. It was not standardized, evaluated on a standardized way, in such way that it was evaluated in every study on the same
way.
It was in every study evaluated standard, but not in the different studies on the same way. And that has to do mostly with ease of use and willingness to continue using in the future. And personally, I think when it comes, for instance, for gingivitis patients, I think the rubber interdental bristle cleaners are a bit easier to use because they bend not so easy. Like those small interdental brushes, they bend easy, and that is not so comfortable for patients. But this is more a personal idea than it is mentioned as such, as an argument, while people are not. It's not the top choice. So that's a personal thought.
Interesting. I see that we're already 53 minutes in, which means we only have a few minutes left. And of course, we want to have the opportunity to answer some questions from the audience. Let's see what we have. I see here, it's a question from Lawrence. Would you recommend other interdental cleaning devices, such as wood picks, floss, interdental brushes, dental picks, or protocols for healthy than for gingivitis or periodontal patients? So is there a certain indication that determines maybe which product or which device you're recommending?
For me, it's easy. We always work with the interdental brushes all the time, and we would focus on peaks when the papilla or the bristle gets kind of smaller. So, like, for example, lower incisors, when there is crowding. I mean, we tend to work on peaks in this regard. This is of the highest importance in subject with periodontitis and subject with gingivitis. When it comes with somebody with no gingivitis, no periodontitis, which is not easy because I don't treat these people, I actually treat people with periodontitis. But theoretically, it's people that have a good, let's say, healthy condition with no gingivitis, no periodontitis, then I might wonder whether I should give anything interdentally or not. In that specific sample, which is really the vast minority of the sample. We're talking perhaps of the 10% of the population. I'm talking about adult population. I would most probably focus just on electric toothbrushing. I think this is more or less our approach.
Mm-hmm.
Yeah, I think our approach is rather similar. I think we both agree that floss is not the first choice. That's also rather in the statements of the EFP. I think traditionally in the Netherlands, also the wood sticks still have a rather big role in gingivitis patients in order to compress the papilla a bit. So that's from a traditional point of view, but you see that the rubber picks taking over the rubber toothpicks take over rather quickly at the moment. But always for periodontal patients, it's periodontitis patients, interdental brushes are the way to go.
I see. Yeah. Thank you for the answering this question. Maybe we have time for one final question. Let's see what Nina asks. Hello, thank you for the webinar. If I dare to ask, what are the reasons of inflammation after using an electric toothbrush? Can the electric brush be a reason of perio problems? Is that something you...
I think...
Well, go ahead.
I think a brush is not the problem of causing, because we also know that different pathology is the reason of a perio problem. What we also know from studies already from several systematic reviews with several different inclusion criteria, that the power toothbrush is superior to the manual toothbrush. And we even know that a power toothbrush is does not cause more damage than a manual toothbrush on the soft tissue, so for instance recessions or gingival abrasions, nor to the hard tissues, and that's what we know already from a systematic review for more than 10 years ago. And it seems that no other data appears that we should rephrase that. So for me, a power toothbrush is not the reason for a perio problem. It's even so that I think if you have a perio problem, you should use a power toothbrush. Right. It doesn't say that with a manual toothbrush you cannot brush, but with a power toothbrush, there is at least a bit more evidence. Filippo, do you agree, or do you have another?
No, well, no, I agree. And I would actually to echo that this is also true around implants as well. It's not just a question of teeth, it's also a question of implants. To create a damage with the brush, with an electric toothbrush, you need really to use it very badly. I mean, because surely the highest damage is without a brush. Let's put it in this regard. But using a brush usually just can make you better. So when there is things like recession or something, it shouldn't be seen in the context of what is brush, but in the context of what is being left or the way things have been built in terms of prosthodontics. So I'm actually very confident to suggest a toothbrush, an electric toothbrush, to any of my patients.
Yeah, thanks for answering this question as well. Let me take down this reference. I have my eye on the clock, and it seems that we are unfortunately running out of time and reaching the end of our conversation. Maybe at the end of this presentation, we can have a look at some key findings and some key discussion points that we found today. Let me try to pull this up. Yes, here we go. Maybe some take-home messages for the people who've been watching and want to summarize what was said today. Home-based oral care is crucial for the prevention of periodontal and peri-implant diseases, as well as for the management at all disease stages. I think that's what we discussed in the beginning. Toothbrushing only removes a certain proportion of plaque. Interdental cleaning is essential for further plaque reduction. Among interdental cleaning devices, interdental brushes are the most effective in plaque removal and reduction of gingival inflammation. In patients with periodontitis, rubber interdental picks can be an effective alternative to interdental brushes, and rubber interdental picks rate higher for comfort, ease of use, and compliance compared to interdental brushes and floss. Just a quick recap on what has been discussed today. Do you have anything to add, guys?
Well, actually, yes. Point number 3. I'm not sure that actually interdental peaks looks even more effective in gingival inflammation in subjects without periodontitis. But of course, this is just a result of my trial that has been also need to be tested in many other trials. Interdental brush has more robust evidence because there are more than one research group. But this is just a little pinpoint thing.
Yeah, thanks for adding this. I mean, this is also indeed what we discussed before during the discussion about the papers. Absolutely. Okay, thanks so much. Let's take this down because now we have the opportunity to say goodbye to everyone. Because it wraps it up for today. I hope we've been able to answer all the questions from the audience. And if not, of course, we will do our best to come back to you afterwards. I also want to thank our 2 amazing speakers of today, starting with you, Dagmar. Thanks so much for your insights. I, for one, have learned a lot today, so thanks so much. And
thank you for the invitation. Thank you for the others, the petitioners, to watch us. Please take care of your patients. Take care of your collaborations with dentists, implantologists, and others in the dental field. And also, please take care of the other people in the world who are in difficult times at the moment.
Absolutely. Thank you for your nice words, Dagmar. And thank you to you as well, Filippo. It was such a pleasure to talk to you as always. Good luck also with all your ongoing projects. Maybe you want to say a few words.
Do our best.
Good.
Well, after Dagmar, I cannot say much. I just echo what she said and send lots of kisses to everyone, and especially Dagmar that I haven't seen for such a long time. And we keep discussing on internet, but we haven't seen each other for long.
See, that's nice. Yeah, good. And also, as always, also a big thank you to everyone who's joined us today in the audience. Don't forget to subscribe to our YouTube channel. You can also find us on Twitter and LinkedIn at Sunstar Global, or just visit our website, sunstar.com or sunstarfoundation.org, and finally, sunstargum.com. We will be back next month on May 5th with another episode of Let's Talk Oral Health, and this time we will focus on home-based oral care from the perspective of orthodontics. So as always, keep an eye out on this channel. Thank you again, and catch you all next time. Goodbye all.
Bye-bye.
Bye-bye.